Terminal palliative care, in which the patient controls their own pain medicine. One example would be a morphine pump. Patients in pain seem to live longer. Those out of pain let go more peacefully. And our guest touched on that just before we broke for the news. But we got new guests lined up, and maybe we'll get into that topic as well and prove Mike wrong. We have on the show joining us now Daisy Chung, the Assistant Professor of Law and Deputy Director and Research Fellow at the Center for Medical Ethics and Law at the University of Hong Kong. Good morning, Daisy.
Good morning. Hi, thank you for having me.
No, thanks for coming on the show. We also welcome David Lam, a lawmaker for the Functional Constituency of Medicine and Health Services. He is also a specialist in general surgery, so a real doctor. Thanks for coming on the show, Dr. Lam.
Good morning.
Good morning. So, we've been talking about this issue of people's wishes being respected in terms of advance directives and their right to refuse treatment. But we're talking about this because there is a law coming to LegCo. David Lam, you are a legislator. Presumably you're going to be involved in the debate today, a vote today. Can you tell us what is the status of this law?
Well, today is really a discussion about a proposal. We have not yet seen the bill so far, but actually doctors, especially in a public hospital, has been practicing advanced medical directive under the framework of common law for quite some time, and it is generally quite accepted by the patients and the families. So we're just codifying the law so as to make it clearer to everyone.
Okay, and so you're saying we haven't actually seen a law yet. Who's going to write this law? The government bureaucrats going to write this law, or are legislators going to be writing this?
The law will be proposed by the government, and then the Legislative Council will vet the law line by line, section by section, and then before that we will discuss the overall plan and also the framework, and that is what is to be done today.
Right, and according to the LegCo paper, the proposed law amendment would better protect health care professionals from lawsuits in future. What is the situation now, Dr. Lam?
I don't think there is a lot of lawsuits regarding doctors and other medical professionals at the moment, but the worry is really more on the paramedics who see the patients on an emergency basis, such as the ambulance crew. There will be very little time to go to check if the patient has advanced medical directive before. So it is really a decision of that particular moment, and if the patients or the relatives, mostly the relatives, tell the emergency medical crew that this patient has sort of an advanced medical directive, at the moment, I think the paramedics are obliged not to follow that directive, but to provide emergency resuscitated service to the patient.
Oh,
that is the law currently.
Right. I was having a quick look at the LegCo paper, and then they did mention a possibility of having a digital version of an advanced medical directive. What's your view on that? Would that help?
Yes, certainly. Now, imagine someone who decided to make his own advanced medical directive when he was still mentally sound. And maybe weeks down the road, he became totally unconscious, and then something happened. And there arises the question whether certain medical treatment should be given to him. Now, that is a stage where the person is totally unconscious, and where do you get that advanced medical directive?
Yeah, where are you going to get it from?
Yeah, where do you get it from? Of course, he would probably has told the doctors that if he is a long-term patient of that particular doctor, then of course the doctor would know, or that he can tell the relatives. But then what about those who has not told the relative, or the relative who knew about it wasn't there, and somehow the doctor heard that this patient might have an AMD? Then that would be a difficult situation. If that is incorporated in a system like the EHRSS or the e-health system, then it will be available to the doctor at that needed moment. But of course, there's also a downside to it. At the current moment, if the patient wishes to delete or withdraw his advanced medical directive, all he has to do is just tear it up. Right. But then if it is inside the e-health system, you can't tear it. You need to do something proactively to remove it or to delete it. And it is quite controversial if someone who is of a relatively advanced age or in a not too good health condition knows how to handle those digital gadgets. So that's the downside of it.
Yeah,
but
I
with
mean,
time, I believe.
How would people even know? Like I'm trying to imagine this, and like I remember in the old days, people used to wear medical bracelets to indicate that they had a condition. I don't know if they had this in Hong Kong, but in Canada, you'd know somebody, I think it was like diabetes or something, and they would have a bracelet. And I mean, would it like a paramedic shows up, somebody's wearing a bracelet, they check, they're like, oh, by the way, what's your mobile number? I need to check your advanced directives. I mean, and then they got to get an SMS, and it's like, would you like to confirm it? Meanwhile, they're dying in the ambulance. I mean, this all seems complicated. Daisy Chung, I mean, this seems like it's got a lot of legal complications, especially in an emergency situation. How do we deal with this?
Yeah, sorry, I was just going to jump in. As far as I know, with the complications with the Fire Services Ordinance, which is the ordinance that requires the paramedics to sort of give life-saving treatment immediately, the proposal is along the lines of, because for them it's really hard for paramedics, to be clear, it's hard for them to read, because sometimes advanced directives can end up being very lengthy, so they can cover a lot of different situations. They cover, what happens in a certain situation A, a certain situation B. So for paramedics, they want something that they can work with. They can just look at one page and they can be immediately like, okay, well, I don't need to, resuscitate, or I do need to resuscitate. They don't want to make these really difficult judgments, like, is this person in a terminal ill state, or is this person, in a certain clinical state? So essentially, for them, what would work is a DNA CPR, so do not resuscitate. And there's a lot of complications there, which I won't go to at the moment. But currently, I understand that the proposal is to have original ADs only be allowed because of the problem that I think David just mentioned about the difficulty to remove or to revoke an AD once it's in the EHRSS. But this has also been subject to some controversy. There was a study that was a very large-scale study that was conducted by the NGO, the newly established NGO, MIP CRC Care Resources Connect, and they did a really large-scale interview which suggested that, the society their sample population was really keen to have a central depository, which is different from the EHRSS and is accessible by the community, so they can upload, download, etc. And there's been some debate about whether Hong Kong is ready for this technology, and the people at this, this discussion of this survey felt that, they were ready actually in terms of tech and in terms of, with the Leave Home Safe, for example, a lot of elderly people, were able to figure out technology in a way that we hadn't expected. And so I think a lot of people do feel that society is ready and it's mature for this kind of central depository, which would make things a lot easier than expecting people to carry, 30 or 40-page AD documents with them. And sorry, just to go back to your medical bracelet, that also is a reason why a medical bracelet wouldn't work in such a scenario, because there are so many different unpredictable scenarios that could happen at the end of life, such that if you just have the indication, well, I don't want to be saved, well, what about in this scenario? What if we're just going to give you this? So it's a very complicated situation which couldn't be resolved by something as simple as, a card or a medical bracelet, basically.
Yeah, I mean, and I guess we're dealing with a motivation issue here as well. You said, Hong Kong's elderly people got motivated. They managed to figure out Leave Home Safe app. Sure, when we told them they couldn't go to Yum Cha.
Yeah.
But, when it was, when it's like preparing for their end of life, they're not usually that interested in dealing with this, as we talked about in the first part of the show.
That's true.
Yeah, so Dave...
sorry, if I could just jump in with one thing I heard at the beginning of the show, which I wanted to very quickly address, was about the idea of sunset clauses, which you mentioned. I don't know.
I'm a big fan.
So the idea, I think this is interesting. So we did a cross-comparative study with 15 other jurisdictions on advanced directives. And Israel is an example of a jurisdiction where the AD only lasts for 5 years. So if you wanted your AD to last longer, you would need to renew it. But the problem with this is, if you lose capacity before you're able to renew, then you are not able to make an AD. So this is a problem for people who, aren't really as on top of things. They don't realize they need to renew every 5 years. And if they lose capacity in the meantime, then they lose the right to have that done. So that is a con to the idea of the sunset clause, although obviously a pro to the situation you guys were discussing just now.
Yeah. David Lam, how much direction or how much input are you getting from other jurisdictions? I mean, have you looked at what the I mean, what countries have done this right? Others who haven't done it right have either neglected it or have implemented a law that has not worked out the way people thought it would. I mean, are you taking direction from examples around the world?
Well, we have to discuss that today. But as you mentioned, there are other jurisdictions who are doing similar things. And I noticed that some jurisdiction set the time limit to the validity of the AMD, which I think, well, is hard to implement because as a colleague just said, if someone becomes unconscious before the expiry or near the expiry of the AMD, then he may just forget or be unable to renew it, and that removes the right of self-determination from that particular person, which is not a good thing to do. Now, going back to the issue of the paramedics, you mentioned about the bracelet. Maybe it is helpful in the sense that it alerts the paramedic that this person has a advanced medical directive, and you can actually have a number, as you mentioned, or a QR code on it where a standard scanner with the paramedics can actually link it up to the actual page of the advanced medical directive. So that is a possibility. We still have to look into it. And then to the paramedics, it is relatively simple. What they are actually looking at is whether to resuscitate or not, but rather than the more complicated issues of whether one gives a Foley's catheter or intravenous fluid or sort of medication or not. So what they have to decide is whether to resuscitate or not. So that is another part of the proposal, which is a standardized page of DNA CPR. And if that is available at the time the paramedics arrive at the patient's home or wherever he is, then they can decide whether to resuscitate or not to resuscitate. As for the more detailed instruction on the AMD, that is usually up to the medical doctors or the nurses to handle.
Is it possible to have a 2-level AMD, one for emergency situations and one for non-emergency situations? Because I mean, as you both pointed out, it's not reasonable for a paramedic to be able to wade through 30 pages of different scenarios. Maybe there's an emergency version that is like resuscitate, don't resuscitate, and let's say, hey, patient, come on. The paramedics got to deal with you. You can't have it. You can't have 50 different options. It's not reasonable.
Well, then you face the difficulty of defining what is emergency and what is not emergency. So the easier way out is to have a DNA CPR, that is, do not attempt cardiopulmonary resuscitation, which is a very straightforward instruction. If you consider that to be the only emergency situation whereby the paramedics have to decide immediately whether to provide CPR or not. And in the proposal, that is a separate form. But then the AMD can be, more complicated, inclusive of more conditions and also more forms of treatment. And that would be usually left to the doctors and the nurses to handle when the patient arrives in the medical facility.
Right. And Dr. Lam, I mean, I know you'll be discussing this further with your colleagues later on this morning. Have you been speaking to them about this? I mean, what do you think will be the main talking point? I mean, what are some of their concerns?
I think whether to digitalize it is certainly one concern. Another is, now, when I get an advanced medical directive from my patient, then a prerequisite is that he or she is mentally sound. All right. Now, it is possible, although I don't think it will be very common, that someone comes out later on and challenges that. How did you know, doctor, he was mentally sound? Did you use any instrument to assess whether he was mentally sound? Now, that complicates issues. Because the doctor who takes care of the patient may be an oncologist, maybe a surgeon, but rarely or seldom a psychiatrist. And it is only the psychiatrist or the clinical psychologist who knows most of those instruments for assessing mental validity. But then it is also our usual practice to obtain informed consent from patients for surgery. And we generally will not use a very complicated tool to assess whether the patient is mentally sound. Now, if this becomes a law and it requires the doctor to ensure that the patient was mentally sound, then that adds sort of an impediment to how this can be carried out, actually. So this is also something I am a little bit concerned about.
And is there a question about the undue influence of pain? Should we be letting people administer their own pain medicine, and then does that influence there? Like
pain medicine, yes, you always can. We now actually encourage patients to use their own decision, their own judgment to administer their own painkillers, including sometimes morphine. And whether that affects the mentality is another issue. Now, but
that's the question I wanted to ask: is if somebody's like dosing themselves with morphine, I mean, is their competence then questioned?
Yeah, but
okay.
That's just what the doctor has to decide, and you cannot go on to the real difficult psychological assessment tools, because very likely one of those requirements with those tools will be he's not under the influence of medicine. And when these patients are almost always under the influence of some sort of medicine because of their illness, then they are something you have to do away with and be very practical. Unless you say that anyone who is under under influence of medicine has lost his right of self-determination, which I don't think so.
Right. Oh man,
someone who is taking morphine, who has severe pain, I still think he should have the right of self-determination. And a doctor's role is to discuss with him, make sure he understands to the fullest extent possible, and make an informed decision for himself. And rather to take away his right of self-determination because he is under sort of influence and he was not 100% mentally sound. I think those arguments are something we have to handle maybe today or maybe in a later stage.
Sure. One of the most important reasons that we articulate human rights is with the intention of alleviating pain, and it seems a little ironic that under the actually trying to relieve pain or taking actions that relieve pain, we could take away a person's fundamental right of agency. Weighty issues on Backchat today. I think we could probably carry on another couple of hours with our guest right now, Daisy Chung, Assistant Professor of Law and Deputy Director of Research Fellow at the Center for Medical Ethics and Law at the University of Hong Kong, and David Lam, lawmaker, functional constituency, medical and health services, and a doctor in specialist in general surgery. Could talk for hours on this. Really great guest, Janice. I'm glad we had them on today. Maybe we'll have to do it again as this issue develops.